Good morning. Bon dia. Thank you very much for your participation. My name is Nuria Fabrellas. I'm a professor at the University of Barcelona. I'm the chairwoman of this session. First, I have to remind you, for those who's joining us virtually, that you can send your questions by clicking the Q&A tab on the right side of the screen. For those with us here in person, you can send your question by first downloading the Congress app. Once logged in, click Q&A and from the home screen and select this session. To get to know the presenters more, you can view their profiles in the Congress app. The title of this session is What is Metabolic Associated Fatty Liver Disease, known as MAFLD. This session is hosted by the University of Barcelona and the European Liver Patients Association under the sponsorship of a grant FISPLAT from the European Institute of Innovation and Technology, AT Health. Before what this session is important, metabolic associated fatty liver, MAFLD, affects approximately 25% of the population and is associated with various metabolic comorbidities. The first therapeutic strategy in MAFLD is modifying lifestyle, particularly diet and exercise. Advanced practice nurses are the most qualified professionals to care of these patients. In addition, these patients with liver disease are more often stigmatized, with results in low self-esteem and impaired quality of life. For all of these reasons, the needs of people with the disease should be known, because the opinion of patients is paramount. This session is divided in 4 parts: natural history of MAFLD and its diagnosis, role of the nurse in the treatment of MAFLD, a stigma in persons with MAFLD, patient perspective, and unmet needs of liver patients. The first speaker is Adrià Joanola. Adrià Joanola is a hepatologist from the liver unit at the hospital clinic here in Barcelona. His research is dedicated to chronic liver disease. He's working as a staff member in the hepatology department in Hospital Clinic de Barcelona. Adrià Joanola is discussing the natural history of MAFLD and diagnosis.
Si tenim la presentació. Okay, thank you very much, Professor Fabrellas. Today I'm going to talk the natural history of MAFLD and its diagnosis. I have no disclosures for this talk, and this is the agenda. We will talk about the definition of MAFLD, its epidemiology, and why the disease develops, its pathogenesis, and after that we will talk about natural history and why it is important, how we have to diagnose these patients with MAFLD, and which treatments are currently available. So let's start with the definition. NAFLD, starts with NAFLD with N, non-alcoholic fatty liver disease, is defined by an excess accumulation of fat in the hepatocytes. It could be free fatty acids or triglycerides. On your left picture, you see a normal histology of liver with its hepatocytes, a central vein, and its sinusoids. I don't know if this works yet. Wait, sorry. No. And in the right picture, you see the white droplets that are the accumulation of the fat in a liver, and this is the pathologic histology. However, recently the concept has been slightly modified to MAFLD, to metabolic associated fatty liver disease, because it's not only the accumulation of fat, but also the association with some other criteria, mainly obesity, type 2 diabetes, or some metabolic risk abnormalities that could be waist circumference increased or increased blood pressure, among others. However, it is important also to rule out other secondary causes that can induce the deposit of fat in the liver, and these causes mainly are alcohol intakes, the use of some drugs as amiodarone, tamoxifen, in fact, the genotype of genotype 3 of hepatitis C, and some congenital and inherited diseases like Wilson, congenital metabolic disorders, and so on. And why it is important and why today we are talking about MAFLD, because as Professor Fabrellas said, the global prevalence of MAFLD is near 25% among all over the world. And in some regions it rises up to 30%, like you can see in Middle East and South America. And this prevalence has been modified and is increasing in some specific groups. Like we talked that general population is 25%, but in specific groups like diabetic population, obesity population, and some inflammatory disorders as Crohn's disease or psoriasis, this prevalence increases up to 90 or 80%. So we are talking about a huge problem, huge health problem. And this prevalence is increasing in parallel with obesity. Here you have a slide, a graph with the prevalence modification from 1975 to 2015, where the prevalence of obesity increased among men and women. And this increasing prevalence took place in all over the world. Here you have two colored maps with the age standardized mean bone mass index that compared in 1975 to 2014. And as I said, as the obesity prevalence increased the past years, also the NAFLD incidence increased. This is obtained from a study in US from a cohort over 140,000 patients, where you can see that the incidence of NAFLD increased among years from 1997 to 2013, and this took place among all age groups. In the red line on the right graph, you can see that the patients with the age in the black line, the patients from the age from 16 to 39, also the incidence of NAFLD increased. So why this disease took place? What it is known is that there is an imbalance between the uptake and intake of free fatty acids. That we know that liver participates in the metabolism of free fatty acids, and when there is an uptake from these free fatty acids that can be obtained from diet or can be released in the plasma from adipose tissue, or can be also produced into the liver. These free fatty acids in the liver have different pathways to go. These free fatty acids can be metabolized in oxidation in mitochondria to obtain energy. Some of these free fatty acids can be converted into triglycerides to be exported as very low density lipoproteins. And some of these triglycerides at the end are stored into the hepatocytes and became the steatosis. And the problem is that these free fatty acids can activate through different pathways the inflammation cascade, producing oxidative stress and endoplasmic reticulum stress that can induce the release of different cytokines and chemokines that activate different immune cell subsets as macrophages, lymphocytes, that in turn activate the hepatic stellate cells that promotes the deposition of fiber into the liver and at the end produces liver cirrhosis. But the question is, if all the patients with NAFLD will go through all these stages, the answer is no. We have a wide range of spectrum of the disease. We have patients that only have simple steatosis, that they only have fat into the liver, and some of these patients will develop inflammation, what is called NASH, and some of these patients will have fibrosis, mild to severe fibrosis, and at the end cirrhosis. It is assumed that the process to go from one stage to another stage, it takes over 7-10 years, but we know that there are some patients that go faster through these stages. We do not exactly know why these patients go so fast, but what we know is that there are several factors that associate the progression through the disease, and these factors are type 2 diabetes, hypertension, and also the weight gain and central obesity. And why it is important to diagnose these patients with MAFLD, and why it is important if the patient has only simple steatosis or NASH or fibrosis. because in this slide you can see two graphs. On the left graph, you can see the whole population, whole group of MAFLD patients that has an increased risk of death if we compare them with general population on the red line. And in the right graph, you can see the different stages of MAFLD disease from simple steatosis to cirrhosis. And as the disease progresses through the stages, they have higher risk of death if we compare them with the general population. And also it is important to establish which grade of fibrosis do these patients have, because as more fibrosis they have, this is an independent predictor of free transport survival among years. But the point is that not the patients with MAFLD, the first leading cause of death is not liver-related events. The first two leading causes of death from patients with MAFLD are cancer and cardiovascular events. And here in this slide, this is obtained from a recent study published in Gut, that patients with MAFLD, you can see in all of the stages from simple steatosis to cirrhosis, have an increased risk of cancer, of developing cancer and dying from cancer, and also from developing cardiovascular disease and have an increased risk of cardiovascular events. And how we can diagnose these patients and to establish which stage they are. We have many tests, many methods have been performed. We have non-invasive tests or methods like serological tests or radiological tests, and also we have an invasive methods that we will discuss later, and it's the biopsy. If we focus on serological tests, there are some that are, not all the tests are useful for all the stages of the disease, but some are for some stages, as in this case the FLI, the fatty liver index, that includes different variables as some lab tests, some waist circumference, for example, and this is useful to rule out the presence of steatosis among patients. And other tests that are useful in patients with MAFLD or we suspect MAFLD is to rule out the presence of fibrosis. The MAFLD score, MAFLD fibrosis score and FIB4 are also useful to rule out the presence of fibrosis. If we don't talk about serological tests and talk about radiological and elastography test, we have the ultrasound and the CAP that are useful to identify those patients with steatosis. However, they cannot rule out the presence of NASH, neither fibrosis. And however, elastography, transient elastography, is useful to identify those patients with fibrosis and try to stratify it. In this slide, in this graph, you have a graph obtained from a study from Llorenç Cavalleria that compared the different non-invasive tests, liver stiffness, MAFLD fibrosis score in red, FIB4 in blue, and ALT, one of the serum transaminases, and to assess the presence of significant liver fibrosis. And he found that that liver stiffness was the best non-invasive test when they compared this test. Here you have an algorithm proposed also from an article from Llorenç Cavalleria, where patients with risk factors like type 2 diabetes, obesity, we talk about that. If they have an increased FLI, an increased fatty liver index, or they have a steatosis in an ultrasound, we need to assess if the patient has or has not fibrosis, and then we can perform the MAFLD or FIB4 test. If the patient has low risk, then we just have to recommend them lifestyle modifications and control other comorbidities, and let's keep assessing the risk of developing fibrosis the following years. But if the patient has an increased an increased risk through MAFLD or FIB4, we should refer the patient to transient elastography. The transient elastography, if the CAP is also available, it should be also performed. Can tell us that the patient has no advanced fibrosis. If the result is low, then refer the patient to primary care and assess this fibrosis every 2-3 years. It could be in an intermediate, a grade zone, or the patient can have advanced fibrosis or what is called cirrhosis. However, independent which stage is the patient, we need to recommend them weight loss and assess cardiovascular risk and other comorbidities, as we saw before. But, however, currently the best test we can perform to the patients to obtain the final diagnosis and to see which stage is the patient and can help us to identify all the stages from the disease is the biopsy. We know that it's not available in all the centers, and it is not probably useful for all the patients, but as here in the slide you can see from simple steatosis on the top on the left, from different degrees of fibrosis. So currently the biopsy is the gold standard in patients with MAFLD, and is this recommended to perform if we have suspicious of advanced fibrosis. And let's talk at the end about treatment. What can we do with these patients? How can we help them? We need to focus, as we saw before, that patients not only have problems related directly with the liver, but also with other comorbidities and focusing on cardiovascular risk. So we need to focus on the liver strategy, on a liver treatment strategy to solve NASH, to decrease the fibrosis and try to stabilize the disease. As it progresses, there is an increased risk of death. But however, we also need to focus on other comorbidities, like focusing on cardiovascular events and improve lipid profile and glucose and insulin sensitization. But, however, currently there are no any specific treatment for MAFLD patients. We know that there are some drugs that are under evaluation, but there's no any treatment that has been already approved to these patients to improve the disease. So the only current options we have is control the risk factors and weight loss. That is sum up in make some exercise and get some diet. Because what we have already seen in some studies is that the weight loss helps to decrease also the cardiovascular risk and the diabetes risk, but also helps the patient to decrease the disease, to regresses the liver disease. If the patient weighs the loss like 10%, it is achieved, a 10% reduction, the NASH solves, the fibrosis regresses, the steatosis improves. However, we know that not very few patients achieve the 10% weight loss that is surged. So to conclude, MAFLD is currently the most common etiology of liver disease in Western countries. We have seen that the prevalence is increasing together with an increased prevalence of obesity, type 2 diabetes, and metabolic syndrome. That the disease ranges from steatosis or simple steatosis to steatohepatitis, fibrosis, and finally the liver cirrhosis. The ultrasound is the preferred method for liver steatosis diagnosis. However, other non-invasive tests as transient elastography or serological tests are useful to rule out the presence of advanced fibrosis. And the biopsy is the current needed for the diagnosis of NASH and inflammation and fibrosis. And we need to identify these patients with MAFLD and advanced disease among the risk groups, okay, to try to identify these comorbidities and try to treat these comorbidities to avoid negative impact on these patients. Prognosis depends on the presence of NASH and fibrosis. As more advances the disease, we know that the patients have worse prognosis. Lifestyle modifications, focusing on diet and exercise, focusing on the weight loss, are the only current available treatments. And it's important to assess the other comorbidities and properly treat it. That's all. Thank you very much for your attention.
Thank you very much, Dr. Joanola. And the questions will be answered by the end of all the conference. Now, Martina Pérez is going to talk about the role of the nurses in the treatment of MAFLD. Martina is graduate in nursing and in anthropology from the University of Barcelona. She's a liver cirrhosis nurse practitioner. She combines healthcare practice with research in the clinical research group, Chronic Liver Disease. She participates in various national and European projects. Martina.
Well, good morning, everybody. First, I would like to thank the organization for this opportunity to share our work with you. Well, MAFLD, or metabolic associated fatty liver disease, is the most frequent cause of chronic liver disease in Western countries and affects around 25% of the general adult population. And as its name suggests, this disease is strongly associated with obesity and metabolic syndrome, and it's now the second most frequent indication for liver transplantation. Well, there are multiple factors that make MAFLD a public health issue difficult to address. First, it doesn't present with any specific symptom until it progresses to a very advanced stage of fibrosis. Second, there is a poor public awareness of MAFLD as a disease and its relation with more severe complications such as cirrhosis, diabetes, arterial hypertension, or cardiovascular disease. And third, there is still no pharmacological treatment approved for MAFLD. The only therapeutic strategy is weight loss through lifestyle change, such as diet and physical activity. Well, the implementation of such lifestyle modification, it's difficult and requires additional guidance and support, which is where the special ed nurse comes in. The special ed nurse can play an important role in patient education. On the one hand, we are in close contact with patients and their caregivers, so we can spend time sharing information on disease prevention and promoting changes related to lifestyle habits and weight loss. And on the other hand, we are in close contact with other professionals such as doctors, nutritionists, and psychologists. And we can also provide holistic and person-centered approach. This could improve the experience of patients with MAFLD and their caregivers in such a way that it could be possible to reduce the need for inpatient care and increase the quality of life. Well, let's move now to talk about the management of the MAFLD patient by advanced practice nurse in a hospital. The patient who arrives in our office for the first time is often very frightened because probably has never had, he has just been referred from primary care to the hospital and has probably had their first contact with a liver specialist already. And most of these patients have never heard anything before about liver disease, and in a short period of time, they receive a lot of information about the treatments and diagnosis and the different complications that can occur. And for this reason, the first question that we do when a patient comes to our office is ask, what did the doctor tell you? It's very important to know what the patient already understood and start building from that point. And to ensure that patients receive all the necessary information, we provide them with clear information using a simple and adapted language, graphic information as reinforcement, and enough time to voice any doubts and feedback questions. As advanced practice nurse in pathology, we usually see two different types of patients with MAFLD. Patients with MAFLD and significant fibrosis or scarring, and patients with cirrhosis. Just to remind, significant fibrosis means that chronic damage has occurred, causing some degree of scarring in the liver. And in short, significant fibrosis is a stage less severe than cirrhosis. Well, for patients with significant fibrosis, it's recommended that the follow-up interval be less than 1 year, and the specific nurse management of these patients is related with lifestyle interventions, such as diet and exercise. And in this stage is perhaps where the nurses can have the greatest impact, because if the patient achieves to change their bad habits and weight loss, it could be possible to prevent the progression to cirrhosis. And when the patients who arrive present at the stage of cirrhosis, they are already at the most severe stage that MAFLD can progress to. And the specific management should be focused on improving the patient knowledge of their disease in such a way that they can control their symptoms and prevent complications such as fluid retention, jaundice, infections, confusing, gastrointestinal bleeding, etc. And in this stage, we still insist on the importance of weight loss, because many studies demonstrate the benefits of this even when the liver has reached the cirrhosis stage. Well, regarding specific recommendations, as I mentioned before, the cornerstone of MAFLD treatment is related with making healthy diet and physical activity and weight loss. And unfortunately, there aren't specific medicines to treat MAFLD, although research is underway to develop them. Research has shown that weight loss is the most effective treatment, and the impact of weight loss on the liver depends on the degree of weight reduction. For example, a weight reduction of more than 5% is usually necessary to reduce a liver fat, between 7 and 10% to improve liver inflammation, and more than 10% to improve fibrosis or scarring. Although even lower reductions can be helpful. Well, the main idea that we try to transmit to our patients is that magical diets don't exist. And we usually tell patients that there are many different types of weight loss, so they can choose the one that they want. And the most important thing is that they have to feel able to keep it up long term. And both the change in diet and physical activity need to be tailored to the individual needs, preference, and abilities. So to be successful, it's important to be realistic and set goals that can be achieved. Well, some examples about the advice that we usually give to our patients in our office are reduce added sugars by reducing sweets, processed foods, sugar dairy products, reduce saturated fat and cholesterol by eating low-fat meat and low-fat dairy products, increase N3 fatty acids found in fish and walnuts, minimize fast food and ultra-processed food, always try to make home-cooked meals, and try to follow the Mediterranean dietary pattern. And also, we usually repeat that any increase in physical activity is useful, even without weight loss. Because, for example, walking, cycling, swimming, etc. Well, about the challenges in motivating patients to undertake lifestyle change, as I said, lifestyle is still the cornerstone aspect on the treatment and prevention of MAFLD. Unfortunately, implementing this change is not as easy as it seems, and we can identify two types of obstacles. First, lack of awareness about the relation between MAFLD and other disease, and second, the difficulty for weight loss. About the first one, in general, people are aware that poor lifestyle habits can cause disease such as diabetes, hypertension, heart disease. But when you tell patients that they need to weight loss or else they will develop, for example, diabetes, they generally understand this because there is a clear relation between poor lifestyle and other disease. However, this is not true for MAFLD. People are often unaware that these poor habits can also cause liver disease, and therefore it's less likely that they will adhere to the recommended lifestyle modification. And about the second one, as you know, weight loss is a gradual process, and it could be easy to feel discouraged if we don't reach our goals at the rate that we had anticipated. For this reason, it's important to improve patients' motivation and self-management. It's essential that individuals with chronic disease are empowered and motivated. And on the other hand, improve knowledge about a healthy lifestyle. When patients become aware of the severe consequence that the illness can bring, there is a stronger motivation to make lifestyle change. It's essential that healthcare professionals, particularly nurses, be able to communicate the specific aspects of the disease in a clear and simple way. And to conclude, the main take message that I want to highlight are the first step and cornerstone of MAFLD management is lifestyle modification, which includes change in dietary pattern as well as increasing physical activity. The most important determinant of improvement of MAFLD is sustained weight loss, regardless of the type of diet followed. And in both these aspects, nurses play a key role in management of patients with MAFLD. So thank you very much for your attention.
Thank you, Martina. Thank you for your speech. Now it's time for Marta Carol. Marta is a nurse in the research group in the chronic liver disease molecular mechanism and clinical consequence at the Hospital Clinic de Barcelona, where she coordinates clinical trials. Her line of research is in the stigma of patients with cirrhosis. She's an associate professor at the University of Barcelona in the subject of public health. Nowadays, she's a doctoral student. Her talk is entitled Stigma in Persons with MAFLD. Marta.
Hello, everybody. Thank you, Professor Fabrellas, for inviting me today at this Congress. I'm going to talk about stigmatization in liver disease, but particularly stigmatization in metabolic-associated fatty liver disease and how it correlates with quality of life. Stigmatization is a well-documented issue in some disease, but some studies demonstrate that patients with alcohol-related liver disease or hepatitis, they often perceive a stigma. Cirrhosis is a stigmatized disease irrespective of the etiology of the disease, but few information exists about it. Hoffman defined stigma as a implied discrediting attribute that transforms the afflicted person from a complete person to someone unimportant and shameful in the society. Stigmatization is a negative attitude where society discredits a person or a group because of an illness. This belief is often related with a lack of an understanding of the disease, that it also attributing it a characteristic like danger or others. Stigmatization has a large array of potential consequences in patients who suffer this disease, like depression symptoms, social isolation, poor self-esteem, shame, and it also reduces the quality of life. Stigmatization has a negative impact on patient health status and the fact that it reduces the possibility of patients to access to care and recovery because they don't want to talk about his disease with other people. As my colleagues explained, metabolic-associated fatty liver disease is the most common liver disease worldwide and affects approximately 25% of the world population. It's a progressive disease where patients can evolve from simple steatosis to cirrhosis or hepatocellular carcinoma. Liver disease are considered as a stigmatized disease and little information exists about that. And it is possible that MAFLD patients are stigmatized is because it affects the liver. The aim of this project was to investigate the frequency and characteristics of perceived stigmatization in patients with MAFLD, and to compare the difference between perceived stigma in patients who suffer MAFLD without cirrhosis and patients who suffer MAFLD with cirrhosis. We want to compare also perceived stigma in patients with MAFLD cirrhosis with those with alcohol-related cirrhosis, and finally to assess whether the perceived stigma correlates with patients and quality of life. The inclusion criteria were outpatients with diagnosis of MAFLD in different stages and outpatients with diagnosis with ILD cirrhosis in clinics of chronic liver disease in the liver unit of Hospital Clinic de Barcelona. Exclusion criteria: age younger than 18 years, diagnosis of MAFLD made less than 12 months prior to the inclusion in the study, associated HIV infection, previous organ transplantation, important linguistic barrier, and lack of informed consent. The main variable of this study was the answer of a stigma questionnaire that patients give to us. We also collect information about demographic data and clinical information. The stigma questionnaire was developed by Valerie Van Sandel, and it's a tool developed in patients with cirrhosis of different etiologies. It's based on 18 stigma-related questions, and the responses are in a Likert scale that goes from 1 to 4, from strongly disagree to strongly agree. The Chronic Liver Disease Questionnaire, or CLDQ, it's a specific tool to assess areas of function important to patients with chronic liver disease. It has 29 items contained in 6 domains that are abdominal symptoms, fatigue, systemic symptoms, activity, emotional function, and worry. And the response went from all the time to none all the time. The most important is 1, and the less important is 7. This questionnaire was validated in Spanish language. A total of 197 patients with chronic liver disease were included in the study. 144 patients with MAFLD and 53 patients with alcohol-related cirrhosis. Among patients with MAFLD, 94 patients with MAFLD were in different stages without cirrhosis and 50 patients with MAFLD cirrhosis. These are the baseline characteristics of patients with MAFLD divided into subgroups, patients without cirrhosis and patients with cirrhosis. The main age are 64 years and the majority are male. As expected, the risk factors for MAFLD were common in this patient, including obesity, type 2 diabetes, and arterial hypertension. In the overall group, the median time elapsed since diagnosis of MAFLD until inclusion in the study was 2.7 years. We want to explain you that the 68% of the patients with of the cirrhosis group were diagnosed with a liver biopsy, and the other have a clinic of portal hypertension. And in patients without cirrhosis, 45% were diagnosed with a liver biopsy, and the remaining did not show signs of portal hypertension. And the median liver stiffness was 6.7 kilopascals. This table is the baseline characteristics of alcohol-related cirrhosis patients and MAFLD cirrhosis patients. The median time elapsed since diagnosing cirrhosis until inclusion in the study was significantly longer in patients with alcohol-related cirrhosis. There were no significant differences between groups with respect to the severity of the cirrhosis as estimated by liver function tests. The main result is that the high proportion of patients indicate they felt stigmatized by answering at least one of the questionings affirmative. The patients with MAFLD cirrhosis has a frequency higher than those without, but the difference was not statistically significant. In the whole group of patients with MAFLD, to investigate whether fibrosis severity was related to perceived stigma, in patients without cirrhosis, we want to divide the patients with no or mild fibrosis or moderate or severe cirrhosis. And there was no difference in any of the domains of stigma, which suggests that stigma is related with MAFLD per se, but not with fibrosis severity. In the whole group with patients with MAFLD, overall perceived stigma show a mild correlation with the total of CLDQ. This relation is negative and reverse, that it indicates that a high stigma, perceived stigma, low CLDQ, low quality of life. This table shows the chronic liver disease questionnaire scores of different domains in patients with MAFLD without cirrhosis, classified according to the presence or absence of stigma. Notably, the patients with perceived stigma show more marked impairment of CLDQ in all domains indicated above of quality of life. Finally, here we have the comparison between the affirmative answer of stigma-related questions divided by each domain of patients with MAFLD cirrhosis and patients with alcohol-related cirrhosis. The frequency of perceived stigmatization was higher in patients with alcohol-related cirrhosis than those with MAFLD cirrhosis. In conclusion, patients with MAFLD indicate they felt stigmatized with all the domains studied of stigma. There was no association between prevalence of perceived stigma and age, sex, educational background, demographic data, comorbidity conditions, including obesity, and presence or absence of cirrhosis. The prevalence of perceived stigma, either in overall score in different domains, was higher in patients with alcohol-related cirrhosis than that with MAFLD cirrhosis. Patients with MAFLD show impairment in quality of life, and finally, patients with perceived stigma show a more marked impairment in quality of life. Thank you for your attention.
Thank you, Marta. Now, I believe that we have a problem. No, we don't have a problem? We have a problem. Okay, of course. Now is the Marco Korenjak turn. He's connected online. Marco Korenjak is the president of European Liver Patient Association, ELPA. In ELPA, Marco leads a team that collaborates in 10 Horizon 2020 projects about liver research. He is one of the 18 most influential people in the world in the field of the hepatitis elimination. That's a problem, that he was to explain that what the ELPA is, what they do, and who they are. Well, in short, she should talk about the patient's perspective, but he has a problem and he is not able to connect it by he's online, but he cannot talk, he cannot connect with us directly. But we have the problem 50% solved, because Dr. Teresa Casanovas is it's the ELPA director and coordinator of the scientific committee. So I'm sure that she can explain us what ELPA is, what they do, and who they are. Dr. Casanovas is specialized in gastroenterology and hepatology. Since 2016, she has been collaborated with the liver patients with the aim of improving knowledge, early detections, and treatment of liver disease. Nowadays is the president of ASCAD, and as told you, is the ELPA director and coordinator of the scientific committee. She's going to talk too about the unmet needs of liver patients. Dr. Casanova.
Good morning. And thank you. Do you hear me? Thank you. I'm very happy to be here because I am from Barcelona and Marco Korenjak is in Slovenia. So the connection sometimes fails. I'm not to be prepared to talk about ELPA. I talk about ASCAD and our collaboration with ELPA, and you can realize the importance of this networking in the point of view of helping patients. Sorry. Yes. The agenda for today is explaining what is ASCAD, is the Associació Catalana de Pacients Hepàtics, concise concepts about chronic liver disease, causes, natural history, progression and complications, the role of liver patients associations advocating for improving care, one example of unmet needs of liver patients, what liver patients need. Patients know what they need, and one example is a white paper on liver cancer in Europe that illustrates their needs, and COVID-19 and some consequences in liver patients' diagnosis and care now. ASCAD is a liver patients association. The headquarters are located here in Barcelona, it was created in 2000 by people who were seeking information and treatment for hepatitis C. From the very beginning, the objectives have been to give information and support to patients in relation to liver diseases. And ASCAT is an ELPA's founding member in 2005. ELPA was founded here in Barcelona during an initial meeting. In 2017, we changed the name, and instead of focusing only on viral hepatitis, we consider all liver diseases. What are we doing? We are meeting our goals, our objective of support, information, and training for patients. We work as a volunteering with projects and activities with a direct attention to patients, our web and social networks in Catalan and in Spanish, educational works and sessions, World Hepatitis Day campaign and other commemorations. You can see now I have a problem, a technical problem, please. Sorry, but it's not managed by this.
Diu que se tancarà la televisió. Hem de trucar amb el dit? No.
Patients may have, in general, complications, hepatic complications, such as liver cancer, related to portal hypertension, or complications related to metabolic syndrome, for example, stroke, high blood pressure, heart attacks, diabetes, or increased triglyceride levels. And liver patients and families need information and support because chronic liver disease may be asymptomatic for years, and early diagnosis allows therapies and best outcomes. So from the healthy liver, we have some inflammation. It produces injury and necrosis and fibrosis, and appears the nodularity of the liver and cirrhosis. It conduces to liver cancer risk, liver malfunction, hepatic failure, and the mechanism is common for every etiology and every cause. The end is cirrhosis. Now I can talk a little about patients' voices on liver disease and the role of liver patients associations advocating for improving early diagnosis and coordinated care. The definition of cirrhosis, it starts cirrhosis at F4 stage. Fibrosis, stage 4, is at the beginning. It be maintained for years, the patient is compensated, and asymptomatic for years, but this patient will need the surveillance because he or she is at risk of having liver cancer. Also, for example, the hepatitis C virus, that now we have the cure with a simple treatment, and the burden of the disease is not only at individual health, is not only at individual level, but has a public health perspective because there is no prevention by vaccination and is a risk of transmission. And also for the healthcare system because it has an elevated cost to care for liver patients. So this is a simple graph. you can see the inflammation produces fibrogenesis. In some point, the inflammation could be regressed because treatments or change of a style of life, but at the end, has liver cirrhosis and possible liver cancer. Patient needs multidisciplinary approach, and they need getting together hepatologists, surgeons, radiologists, including interventional radiologists, for example, for liver biopsy or managing liver tumors. Multidisciplinary expert care can improve outcomes for patients with cancer, and this is published results about improving survival. For the discussion, I have two questions. Do you have a disciplinary team experienced with diagnosis of and treatment of liver cancer and liver disease near? This is a question for primary care doctors, primary care teams, and also for community associations. Do you have an expert or academic center or a tumor board that you can consult with specific patients? We have, and we have a lot of collaborators. In an anonymous way, they can help the patient in order to inform, to accelerate some type of coordination. So, unmet needs of liver patients, undetected barriers. What do they need? We, as a patients in the association, know that patients need information about prevention of liver diseases. Patients at risk of liver cancer need surveillance programs with echography every 6 months. They need an early diagnosis that can allow better therapies, including liver transplant. They need coordinated care and right diagnosis. They need a multidisciplinary team and updated medical therapies, possibly sequential or combined. They need clinical trials with new therapies, approved and affordable, based on scientific evidence and with better results in survival and quality of life. Recently, we had the launch of white paper on liver cancer in Europe. This was a document that was launched on 26 October recently, and this document was presented to the European Parliament. This is a proposal from groups of patients in Europe, ELPA and Digestive Cancers Europe, DICE, and this document will be published in the web pages of these associations, and is planned to be translated in different languages in Europe. This document tries that no patient will be left behind, and is calling for increased equality of best practice implementation, prevention, early diagnosis, and management of liver cancer across Europe. It's a comprehensive document presenting the problem of HCC in Europe, covering information on 5 improved areas. The little note about consequences of the COVID pandemic on chronic liver disease. This is very important for patients, and we have to take it into account. So the impact of delaying the programs of hepatitis elimination has not been published yet, has not yet been published, but mathematical models have evaluated and helped to understand the possible impacts on hepatitis C disease and mortality due to the programs on hepatitis C delays. In many hepatitis elimination programs, COVID-19 has resulted in slowing or stopping altogether. A 1-year delay in hepatitis diagnosis and treatment could result in an additional 44,800 liver cancer and 72,300 deaths from hepatitis C globally by 2030. Countries have committed to hepatitis elimination by 2030, so attention should shift back to hepatitis programming as soon as it becomes appropriate to do so. You can see on the right the consequences, the increasing of tumors, and on the left, the new diagnosis and treatment, missing treatments that won't be started. Also, in this graphic, you can see the unprecedented consequences on cancer care that may have direct consequences on patients and caregivers. You can see that in the period, in the half, we have only partial healthcare recovery because we don't have enough presential visits. As conclusions, patients' involvement and empowerment are urgently required. The ignorance about liver disease favors the persistence of stigma. It is necessary to ask for the systematic implementation of existing clinical guidelines in Europe. Health education awareness about liver is crucial through media campaigns and also at the legal level to protect citizens' health, to promote healthy eating, and to advise on the risks and toxicity of alcoholic beverages. In the future, the attention of the liver patient will be increasingly multidisciplinary and in many aspects with a public health look. As for liver diseases, much work needs to be done. What patients need about liver diseases? You know, we need more information, more work on prevention, vaccination, anti-hepatitis B, early diagnosis, treatment, multidisciplinary teams, and greater participation in programs that affect patients. Thank you for your attention.
Well, it's time for the questions, but before the questions, let me read one WhatsApp from Marco Korenjak. One moment. Marco Korenjak asked me to read these WhatsApps. In the name of all liver patients of Europe, I would like to extend my gratitude to the organizer and all excellent presentations today. It's important to work hand in hand with nurses and other medical experts. In the name of the liver patients, I would like to extend my gratitude to all medical experts fighting COVID today and other diseases tomorrow. Well, thank you very much, Marco. That's his message. And now, if you have some questions for the speakers, it's your turn. Cubrí yo. Gracias. No, there isn't any question. But I have some questions for all of them. I would like to ask Dr. Joanola if it's necessary to biopsy all the patients with MAFLD.
I don't think it's necessary to biopsy all of them. However, as I explained before, the biopsy is the only diagnostic test that can diagnose all the stages. I think biopsy should only be used in those patients we have suspicions of other etiologies like IC or some other diseases, and also if we suspect that the patient has advanced fibrosis, and also the biopsy is almost mandatory to include the patient in any trial. But if the patient is not going to any clinical trial, or we only suspect a simple steatosis or a mild inflammation, there's no need to biopsy all of them.
And when the primary health care need to be referred this patient to the hospital?
This is a good point because we receive many patients with MAFLD in specialist consultant. I think that patients with MAFLD can be managed in primary care assistant if they do not have fibrosis. So if the patient has fibrosis suspected by any of the scores I mentioned, like MAFLD or FIB4, they should be referred to specialist. But the patient needs to undergo a transient elastography, and sometimes it is not available in primary care settings, so the patient should be referred to at least a specialist and to perform the transient elastography. If the patient has no advanced fibrosis, then can be followed up by a primary care doctor and assess the fibrosis every 2-3 years.
Okay, thank you very much.
Thank you.
Martina, I want to know which are the main difference between the role of the nurse in a hospital and the role the role in the primary healthcare nurses with the MAFLD patients, of course.
Well, as I explained during the presentation, in the hospital we usually see the patients who have reached the significant fibrosis stage. What it means that they are in a more severe stage than other patients with MAFLD. And in fact, the treatment that we can offer is basically the same that can offer in primary care, because it's related with change by lifestyle habits and weight loss. But I think that the main difference is related with the patients who arrive in our hospital are more afraid and more aware about the bad consequence or the severe consequence that the illness can bring, can produce. And I think that we can take advantage of this. And it's a good moment to support them to make this change related to lifestyle habits. However, in my opinion, I think that it would be important improve the connections, or the relation between primary care nurses and primary care in hospital, in such a way that it could be important, detection early these patients and start to work as soon as possible to change these habits and to help them to weight loss.
Thank you. I have another question, just is a personal interest. What happened with the person with a normal weight and with MAFLD? What do you do?
Yes, sometimes MAFLD can develop in people with normal weight, and what this don't mean that these people are metabolic healthy. So people with normal weight with MAFLD can also benefit of try to reducing added sugars or try to reduce ultra-processed foods. And for this reason, we insist in these patients that it's necessary increase the physical activity and follow, for example, Mediterranean dietary pattern.
Okay, thank you very much. I have another question for Marta Carol. What can we do to eliminate the stigma in the liver diseases?
Well,
if you
well, the first thing to do is to in more studies. We analyze self-stigma, but we can analyze also public stigma, and the most important is the structural stigma, was systemic in this disease that are stigmatized. If we spend enough money or no in investigation and compare these ones. But one thing that we can start doing right now is to talk more about this disease. Like talk about them, not in public scientific publications, even in mass media. All the mass media, we can talk about more about this disease. If we talk about this disease, all population can learn about them, and we can eradicate the lack of understanding of this disease, and maybe not eradicate all the stigmatization, but maybe few of them.
And as nurses or physicians, what can we do in order to reduce or to improve the stigmatization?
Being near the patients, but also being with open mind with these patients. We work with liver disease, patients that have liver disease. So for us, it's difficult to answer this, but it's true that there are some sanitary people that stigmatize also these patients because they don't have the understanding. Maybe these sanitary people needs more information about the liver disease to not stigmatize.
Okay, thank you for your opinion. Dr. Casanova, what do you think that the society and the professional health can do for reducing the stigmatization?
I think we in the association have worked a little about this, but we are thinking about, and our point of view, and is immediately we are doing, is to be alert with the language, because this is very important to take into account, because people is, for example, we talk obese children. Obese children, it seems normal, but it is awful for me. We have to be conscious that we have to talk about children with obesity, because it's not for all her life that she or he, because in one time that obesity is increasing, it starts in the childhood. So this is once. And also cirrhotic people, it's not good. We have to say this man or this woman has cirrhosis, but it's not forever. So it's not a condition. So we should be alert in this, and we have to take into account also the media. And we are alerting some titles in articles that it's awful. So I think we have a lot of work to do in this aspect of stigma, to maintain the language, but maintain the person with liver disease.
Okay, thank you. Now I would like to know if it's possible, because I know that it's difficult. In your opinion, how can we solve these unmet needs of the patients or persons with some chronic liver disease?
We need a lot of work to do and change our mentality. For example, we are seeing the patient as a doctor, as a clinician. I was a clinician, but now I am a representative of patients. So you can see their needs. People are afraid of the diagnosis. They have received all the information through their teams, through their doctors, and they call to the association. And we have to be calm, to repeat, to maintain what doctors are saying, to say that they have to follow the advices. But it is different that one patient nervous or with anxiety, in shock after a diagnosis, can phone, and one pair answer with calm, with all the time, and this is incredibly good. But also, as associations, and Marco is trying to do everything, is contact with all the European doctors' association and research teams, because they need the voice of the patient also. but not in a patronizing view. Patients can help a lot, and doctors and researchers could be very useful explaining in easy ways you need a liver biopsy, because I know one big association from United States that this association is totally against liver biopsy, no conditions. So this, for me, is incredible awful, because the patient who needs liver biopsy, because, for example, if they have to enter in a clinical trial, or if after liver transplant, perhaps the doctor is needing differential diagnosis in order to treat. And I think we have a lot of non-invasive methods, but sometimes we need liver biopsy, for example. So we have to put more meetings together, try to join more our ideas, and I think this is increasing the perspective.
And what happened about the politician?
This is a very important question, because few politicians are aware of liver disease. For example, here in Spain, we have very good hepatologists, very good teams in liver transplant, the best country for liver transplant, but we don't have all the treatments approved for liver cancer, for example. Here in Catalonia, we are the only community where a drug approved in the other communities is not approved for liver cancer patients as a second-line treatment. And this thing, I think, is very sad. And belonging to ELPA allows us to see different perspectives. For example, in some countries, I don't say names, belonging to the European Union, they had a vaccination program for hepatitis B 2 years ago only. So this is terrible for the population. And politicians are not involved in liver enough. For example, in Portugal, they have decided to put in charge of the liver program, no hepatitis program, because now here we have hepatitis program, but hepatitis program for elimination is with HIV, diseases of sexual transmission, drug users. So I think this is increasing the stigma, and it's not practical. We need a liver disease program with a structured program, joining teams, sharing protocols, and this is our voice. So now in ASCAD, we will have the interview with the professor Rui Tato Marinho from Lisboa. And we shared in the interview 5 pages, very amazing men and fighting for liver.
Okay.
Yes.
Thank you. Doctora Casanovas, just a few words. Could you give us a home message about
Yes, it's very simple. It's very simple. The voice of the patients is needed. And we need us as a researcher, clinical trials, clinicians, psychologists, dietitians, multidisciplinary team, since the beginning, early diagnosis. But you need the voice of the patients.
Sure.
Seriously.
Mm-hmm.
In ELPA, we have different working groups for different aspects of liver diseases. And this is it's very important enrichment for liver diseases, because liver disease is not only hepatitis.
Okay.
So,
For the other speakers, if they want to give a short take-home message, which one would you like to say or to give?
Talk more about liver disease, please.
Martina?
No, I'm agree with Dr. Casanovas, and I think that it's very necessary take seriously the voice of our patients and take time to help them and try to understand and sharing information about how they're feeling about the management of this disease.
For you?
Yeah, and if you should be, clinicians and all health-related workers should be aware of MAFLD, and because it's increasing the past years and it's going to increase the next year, so be aware on liver function test and liver status of the patient and focus on MAFLD to diagnose them and to treat them properly.
I want to give a message to take home, that is eat a healthy food, a Mediterranean diet, and move. Now, by the end, I need to give some reminder. Could you please... Okay, the first reminder is share your key takeaway from the session and post it in the Congress app and on the social media. Remember to use the hashtag IHF Barcelona. The second one is the recording of this session will be available on the event platform in a few hours, and you can access this and other sessions recording for 1 month. We'll have a lunch break at the catering area downstairs, and the next set of sessions will be start at 1:30. Those who are here with us in Barcelona, we hope you can enjoy the after-work social dinner at the Museum Nacional d'Art of Catalonia tomorrow. If you haven't purchased a ticket yet, please go to the registration desk. Thank you very much for your attention. Thank you very much for being with us and for the opportunity that you gave us to share our knowledge and our concerns and our... that's all. Thank you very much.